Fuchs and anterior basement membrane dystrophy, also called EBMD, can oftentimes exist together, and if that's the case, both can be addressed at the same time during surgery.
So this is an amazing video of the two surgeries being combined in the operating room, first starting with the anterior keratectomy to smooth out that superficial part of the cornea.
And you can see that in the center, this is not now smoother than it was beforehand. Initially, you could see some irregularities, and that's the epithelium coming off, and then any irregularities on Bowman's being removed as well.
Healthy corneal epithelium has a hard time coming off with manipulation like this, but because this is unhealthy, poor adhesions of that epithelium, it looks like it comes off really quite freely and easily there.
Yes, so no alcohol is being applied that would otherwise destroy the hemidesmosomes. Here they just come off by itself because, again, there's poor adherence between the corneal stroma or Bowman's and the epithelium.
The same technique, sometimes we'll see this done at the slit lamp with an instrument like a golf spud, for example. Here we're just seeing the example of it in the actual operating room.
Yes, a sharper instrument in the operating room, just because I don't have a foreign body spud in the operating room, but I wouldn't want to use a blade in clinic, higher likelihood of damaging the cornea.
Now we're seeing the outline for the DMEK. The endothelial removal is going to be taking place behind on the back side of the cornea. What's your size that you're targeting here?
8 millimeters on this because the graft is 7.75 and it should ideally undersize the stripping, meaning the stripping should be larger than the graft. I inject myocol to constrict the pupil, a parasympathomimic, which works on the sphincter, thus constricting everything.
You said that the graft size is a little smaller than what you're removing.
So there's a natural tissue, then a gap, and then the graft. And the reason why it works in DMEK, again, Mark Terry, I think, demonstrated that there's a higher attachment rate with undersized grafts, the theory being that the graft attaches better to stroma as opposed to Descemet.
Got it. Okay. So here we're seeing the actual Descemet being removed. That's bringing endothelial cells with it as well.
And yeah, it's stripping. Here you can kind of see air provides better contrast. You can see this membrane kind of folding over with this little hook as I pull, and that can then be removed. Air provides better visibility as opposed to liquid. Also serves to coagulate any blood should there be something from the iridotomies that are created with the needle beforehand.
Is air always used during this part of the procedure?
No, you can strip under viscoelastic, maintain space, or you can strip under saline, whatever you think works best. The reason why I chose air is, again, just better visibility without adding more things to the eye and to provide better coagulation should there be any bleeding from the iridotomies that are created initially. The iridotomies are there so that I don't create a pupillary block. So this is, for example, viscoelastic, and that's when I remove the rest of the...
I see. So still having to get the rest of that tissue.
And here you see the membrane as well, but just not quite as easily as under air.
So very thin, fine tissue. This is just the very back layer of the cornea, just the endothelium with its basement membrane, the Descemet membrane. Its function is to pump fluid out of the cornea. Patients get to this point where they need surgery when those cells are not working properly and the cornea is starting to swell up with a lot of fluid.
Correct. And then here I place that little piece of tissue, the disc, onto the cornea, more to make sure that I removed everything that's intact.
And continuing with the next portion of this just looks like cleaning in the anterior chamber.
Removing the viscoelastic. If viscoelastic in the eye, the graft won't attach, so I want to clean everything out before I inject the graft, and they inject the graft. So in checking one more time with air, make sure I have a nice edge, and then removing also the air before placing the graft. This graft comes folded up in a glass tube and it's stained with trypan blue, thus it's a blue little scroll.
And now we're about to see just that outside of the eye and about to get inserted into the eye through a wound at the side of the cornea. How large is that wound typically?
This 3 millimeters, and what I do with the turning is to determine orientation before I even put it into the eye. And you saw how quickly and how small that tissue is. It's very easy to also, by accident, have the tissue come back out. So this is the most stressful step right there that you saw. And that's why I place immediately a suture afterwards to decrease the likelihood of the graft coming immediately back out of the eye.
Typically, would you say only one suture is necessary, or sometimes do you need a suture on both sides of the graft tissue?
No, again, graft is not held in place with the suture. This is just on the wound. And the suture, one is usually enough. I have seen, though, grafts also come back out. The good news is that you can usually still use it even if it comes out of the eye. And there's a little notch that you'll see inside the graft tissue that tells me what the orientation is of the graft. And here, 2 little cannulas I use to unfold the graft because you're not allowed to touch it inside the eye because it's so fragile. And again, this little notch here tells me that it's the correct orientation because the endothelium is, when it rolls up on the outside, it has to be unfolded with the endothelium down. If it's up, the graft won't work.
And I'm glad you mentioned that about the stitch, because I've always been under the assumption that sometimes a stitch would pass through the DMEK graft, but is there ever a case where that happens, or it's only just purely to keep the cornea closed?
Here, to keep the cornea closed, there can be an instance if it really won't attach and you like really want to force it, that you pass a suture through the whole thing. I do this more commonly in DSEK rather than DMEK, but I mean, yes, I can create a case where you would suture DMEK as well, as opposed to DSEK.
Air bubble going in at the end, that's going to stay in the eye for about a week, and that's going to hold that graft tissue back up against the back of the cornea until the adherence can occur.
Right, and the gas that I use is called SF6, which stays in the eye a little bit longer than air. Air would usually go away after like about 3 days. SF6, the concentration is 16.6%. Very commonly it's also 20%. That doesn't expand, but gets absorbed a little bit more slowly than air.
So a DMEK, is that what the gas you're using after a DMEK?
Yes.
DSEK, different type of gas? Got it.
Yes.
And that'll absorb much more quickly.
Correct.
Okay, great case. Thank you.